Respected doctors, on behalf of JIP Academy, I greet each one of you who is watching this program. So, today's topic, which is going to be syncope. So, the syncope is a very common incident we come across in day-to-day practice. So, what do you mean by syncope? So, how will you define syncope? So, syncope is transient loss of consciousness and a transient loss of postural tone of our body. So, strictly speaking, syncope should not last for more than 1 minute. So, what it has been told in the literature, if somebody's consciousness is lost more than 1 minute, then probably you have to reconsider the diagnosis of syncope. So, syncope generally leaves any person with no damage. So, syncope generally has to be differentiated from seizures, which deserve separate treatment. So, that is why any patient who was brought with the state of syncope, we used to ask any accompanying symptoms, any history of tongue bite or spontaneous urination or a sweating or any autonomic instability, then probably you have to think of seizure. So, what are the causes of syncope? So, basically syncope is nothing but there is a temporary cessation of cerebral blood flow. So, if you know the factors which are helpful in maintaining cerebral blood flow, then probably you can easily assume the causes of syncope. So, cerebral blood flow is maintained by, first most important, your body's vascular tone. So, otherwise called systemic vascular resistance. So, as long as your venous blood vessels maintain good tone, so good amount of venous return goes to the heart. So, from the heart, brain receives good amount of blood supply. So, what happens when your venous tone decreases, or when especially when your veins are dilated, then what happens? The venous pooling occurs in the extremities. So, venous return comes down to the heart. So, cardiac output comes down. So, automatically patient develops syncope. So, what are the situation where your venous pooling occurs? So, first most important is vasovagal syncope. So, what do you mean by vasovagal syncope? So, when you face unprecedented situation like prolonged standing or without any sleep, or sometimes painful injection, or when you are in a crowded place, what happens? Because of that, your sympathetic withdrawal occurs. So, sympathetic system that is the one that is responsible for your venoconstriction. So, in vasovagal syncope, what happens? Your sympathetic system withdrawal occurs. So, what happens? Veins becomes dilated. So, naturally venous pooling or venous pooling occurs in the extremities. So, venous return to the heart comes down. So, naturally cardiac output comes down. Then your cerebral blood flow is compromised, syncope occurs. So, vasovagal syncope, most of the time it is diagnosed by means of history. So, one is the prolonged standing or any pain, or when you are in crowded place, or sometimes the medicines also can produce vasovagal syncope. This is the only one. And second one, then carotid sinus hypersensitivity. So, when you have carotid receptors in the carotid blood vessels, when you do hyperextension, or sometimes when you put on the shirt with a tight collar, if it triggers the carotid sinus, again the patient develops bradycardia, then automatically patient goes for syncope. That is another cause. And this one type of syncope, okay. And another important is any cardiac arrhythmias that may lead to syncope. So, in all elder individual group, suppose 160 plus elder man comes with history of syncope, 1 minute transient loss of consciousness, please rule out MI or pulmonary embolism by means of ECG or echo, or maybe some forms of arrhythmia may be there. When you take ECG, some ECG may be absolutely normal. These patients deserve Holter monitoring to rule out any ventricular tachycardia or any kind of bradyarrhythmias may be ruled out by undergoing Holter. So, any elder individual group, if they complain syncope, always think of cardiac origin. Go for ECG, echo, and third one Holter monitor too. And another important cause of syncope is posterior circulation ischemia. Sometimes what happen when you develop some occlusion in the posterior circulation like vertebral artery and basilar artery, patient may go for sudden loss of consciousness. So, what happen? So, they may not have florid neurological signs like a paresthesia or dysarthria or diplopia. They may have only transient loss of consciousness. So, this patient deserve MRI brain and MR angio. MR angio may reveal carotid artery occlusion which may require intervention. And another important cause, sometimes metabolic disorder may cause syncope, like sometimes rarely hypoglycemia and hyponatremia may cause syncope. But the most important thing is syncope has to be differentiated from seizure. Suppose if patient gives any additional symptom like tongue biting or spontaneous micturition or symptoms of postictal state, like despite the recovery, if patient has altered behavior, once they recover from the loss of consciousness, if they have altered behavior, agitation, then these are symptoms of postictal state which may be suggestive of seizure episode. These patients should be subjected to EEG to rule out seizure. This is another important, you should not forget about it. So, what I want to insist that syncope, it has causes starting from benign cause like vasovagal syncope to some most significant deadly origin also, something like arrhythmias in the elder age group, or it may be a posterior circulation ischemia. So, my suggestion always would be, if any patient presents with future of syncope, always you try to differentiate from seizure. Even you can go to an extent of an EEG, electroencephalogram. Once you differentiate from the seizure, then if you are dealing with only syncope, if it is an elder age group, if they have additional comorbid illness, go for ECG and echo and Holter monitoring to rule out cardiac origin, and go for MRI and MRA to rule out posterior circulation ischemia. So, I think that with this you have understood what is the concept of syncope and how we can evaluate. Thank you.